Many times when we're talking about case treatment planning with patients, they come with anatomic limitations in terms of either we're talking about perhaps, and we'll get into our augmentation procedures perhaps too, if you will, being from the Midwest, tilling the field, getting ready for the crop. That's what I tease my patients about. But sometimes they come and we're not able to till the field, or we're just going to have to work with the anatomy that the patient presents with. We do have implant designs. We have shorter implants now, and there is a move to more and more narrow implants, trying to stay still with a modular or two-piece flexibility from a prosthetic perspective. What are your thoughts right now? Let's start with short implants. Do you see that really impacting on our oral implant therapies?
Yeah, I think it has affected my practice a lot. I've definitely in the past about 3 to 4 years, I've been doing more and more short implants. The 6mm implant by Astra has been a wonderful addition to my practice. At least at this point, I certainly feel that I've been able to do cases on short areas, posterior mandible, over a nerve. As you know, it's very hard to get vertical bone growth. It's not that you can't do it, but the number of millimeters that you can get is a bit minimized, although you always see cases on the lecture circuit, I got 10 millimeters of bone. And they may have, but and some of the great clinicians in the world, but there's great risk involved also. There's morbidity. There was a great paper recently, just came out in the European Journal of Implantology, that showed using short implants, like 6mm implants, versus doing augmentation, both under sinus, but also in the mandible, both. And they showed that the success rate was the same, whether they grafted or not, at least in the short term. This was 1 to 3 years, so it's still short term. Okay. It's not like 10 years. We haven't been doing it for 10 years. But what was interesting, the morbidity was near zero with the short implants. You know, you just put the implants in like any other implant case. But the morbidity, when you start doing hip grafts and you start doing chin blocks and you start doing ramus blocks and GBR, guided bone regeneration, your morbidity goes up, including nerve damage, including to the donor side, to the recipient side also. So we're starting to see that we may be the easier way to do this and get the job done, at least initially, maybe the shorter implants. Now, we're seeing if we have 6mm of bone, I'm using them routinely now. I used to try to do the vertical augmentation, and I have successes on it. I also have failures on it because the tissues gets pulled open, and it's very hard to get a passive closure, especially on the mandible. In the mandible, I think it's certainly going to be distal mandible. We have you have a short height. It's now become, I've had very good success with these. The reason why I'm still saying the 6mm certainly give us a great option, but the database is only about 3 to 5 years old. Max 5 on the real short ones. And so any decent articles on it, good randomized control type studies or split mouth, something that we can hang our hat on, not just a case report, that looks good. Because we have to look at statistical numbers, as you know. You're a scientist and as a prosthodontist, you know that we always have to go back to evidence-based data. And the evidence base now at 3 to 5 years looks great. However, we're not sure what's going to happen down the road. What about 10 years from now? Will we still be as happy? We got to make sure these people have attached gingiva, make sure these people have excellent hygiene, and these implants should all have a platform switch. Okay. Because this goes back now. Now, before I was talking about the horizontal component, but what does the platform switch do? It also decreases, as I mentioned back here, it decreases this vertical piece instead of going 2mm down.
Where you've lost a third of
Picture a 6mm implant and 2mm typical loss from biologic width in the past without a platform switch would give you only 4mm holding the bone. So you're giving up 2mm just from biologic width reformation of taking on an abutment on and off. So the platform switch, if we can control this to near 0 or 0.5, now at least I got 5.5 to 6mm still in bone, and that's what we want. So the key is to keep any periodontal disease in the future down. Now, Astra's had a very good track record with that surface of minimizing periodontal problems. No implant's immune. No one's immune. Even the old machined implant certainly had some, but less than some of these textured implants. TPS, on the other hand, that's why it's not on the market anymore. TPS would look great initially, but if it got exposed, not everybody, it was about 10% of their cases. So it was 90% is still functioning perhaps greatly, but 10% of their cases, if they got exposed, this rough surface would allow bone loss to be too great.
What about the narrower diameters? You start talking about the minis, but let's talk for a second about, from my perspective, I like to have implants that are give me a range of flexibility over time, and so I tend to like modular types of implants so that I have a range of opportunities. Your thoughts about something like a 3.0, which has been on the market for a while?
I think the 3.0s are great implants. I think you need something like that in your armamentarium for lower anteriors, and the maxillary laterals in some cases. For a permanent restoration, to get lower than that is going to be, I think, a bit too weak if you have a two-piece implant. That's why you don't see any, because you hollow it out. The other implants that are narrower than that would be one-piece implants. They have to be one-piece because they don't have the strength to be a two-piece and be that narrow, to have an internal opening and a connection. So that's the problem with the implants that are below 3 millimeters. Even if they're alloys, the type 5 titanium, which, as you know, is harder and more fatigue resistant, you're still going to just can't get lower than that and still have enough room to make the attachment and not hollow it out too much.